and sport-related injuries of the elbow. We have here with us the most experts in this field from all over the world. So on behalf of me and my colleagues here, I highly appreciate your presence in this webinar. I know it was inconvenience for some in regarding of timing, but thank you for joining us. Next, we will proceed to Dr. Ahlam Arnaout for DIC plication in advanced scapholunate injuries. Dear Ahlam, please.
Hi, everyone. Do you hear me?
Yeah.
Yes.
Perfect. So, hi, everyone. Thank you again for the invitation. I'm very honored to be here. Thank you to Dr. Ali Okhofadbour for the invitation. So, in the continuation of Professor MATHOULIN's lecture about scapholunate instability, the physiopathology, and especially the ADCLR technique, the arthroscopic dorsal capsulo-ligamentous repair, I will be presenting one of the possible techniques, surgical technique that we can use, especially in the high-grade scapholunate instability. This is the arthroscopic plication of the dorsal intercarpal ligament. We have seen just before the importance of the dorsal extrinsic ligament and especially this ligament. So I would like to thank my co-presenters, Christophe, MATHOULIN, and Gustavo Gomez. So just to remind you, in the scapholunate instability treatment, a number of procedures have been already described, and there is no real consensus on the ideal treatment according to the stage, and especially on the high-grade instabilities and chronic cases, we are not really satisfied. We have poor and fair outcome at the long term. So we have just seen the importance of the scapholunate complex, and especially the dorsal intercarpal ligament. The dorsal extrinsic ligament play a crucial role in the proximal row dynamic stability. They act as a proximal row labrum, and especially this proximal subsection of the DIC, the scapulotriquetral ligament. And in the open techniques, we have some concerns because we need to cut and we need to pass through these crucial ligaments. So here is again the prominent role of the dorsal radiocarpal structures, not only the DIC, but also the DCSS, the dorsal scapholunate ligament. We have just seen this before. And all these ligaments are the basis of all the ADCLR techniques, what we commonly call the capsulo-ligamentous. So nowadays, we don't talk anymore about the scapholunate ligament tears treatment, but definitely we talk about the scapholunate instability treatment. And in the ADCLR, the arthroscopic dorsal capsulo-ligamentous repair, the aim is to stabilize the scapholunate joint by stabilizing these dorsal structures of the scapholunate complex. So we target in the ADCLR techniques, the DCSS, the dorsal part of the scapholunate ligament, and the dorsal extrinsic ligament, especially the DIC. So it is not a direct repair of the scapholunate ligament. It's very important to understand this. It is the principle. It is a stabilization of the scapholunate joint by capsule to ligament suture. And the main principle is an arthroscopic retightening of the dorsal radiocarpal structures. So here is the original ADCLR, just to remind you, two parallel sutures. And as we've seen before, when we tract on the suture, we apply the dorsal capsule on the dorsal scapholunate ligament. So the enlarged modified technique was already described and used. The aim is to increase the amount of dorsal structures that are included in the suture to increase the retightening of these structures. And when we compare with the original ADCLR, the simple suture, we see that the retightening effect is more important in the enlarged technique. So this modified technique showed interesting results. We have some persistent instabilities, especially in the high-grade instabilities and in the chronic cases. So here is the principle of the DIC application. In these cases, the aim is to increase the retightening effect with the application of the DIC. So the objective here is to describe the arthroscopic DIC application procedure in the high-grade scapholunate instability and to present the preliminary results. So it's a retrospective study. All the grades, the instabilities greater than EWAS 3T were included with a minimal follow-up of 1 year. The EWAS stage was confirmed intraoperatively, and the scapholunate space stabilization was considered intraoperatively either complete or satisfactory or incomplete. So the follow-up was made at 3 months, 6 months, and 1 year, and by the clinical and the imaging assessments. And the Watson test was very important in the clinical assessment. The non-inclusion criteria were the complete disinsertion of the DIC, either from the triquetrum or the scaphoid, and the associated lunotriquetral instability, the cases of floating lunate, the perilunate instability non-dislocated. So here is the technique, the first enlarged technique from ulnar to radial. Retrieve the suture. Here is the first enlarged suture and the second one. And here we can see that when we tract on the suture, we perform the DIC application. So here is the technique. We use the usual dorsal arthroscopic portals, and we add an additional portal, the modified MCU between the MCR and the MCU portal, the MMCU. So the first step is a radiocarpal and the midcarpal assessment. First, we perform here the DCSS test to check the DCSS evaluation, and the scapholunate, the dorsal scapholunate ligament as well. At the midcarpal assessment, we stage the instability according to the EWAS classification. And it is very important, so this step is very important in the chronic cases, to debride and to refresh all this dorsal structure in this area, in this dorsal area, which is the area of the DCSS and the DIC as well. We check also the insertion of the DIC. Here is the insertion on the triquetra to make sure the DIC is not completely disinserted. So we perform the first sutures, 2 parallel sutures entering from the 3-4 portal here. We enlarge the 3-4 portal from ulnar to radial with a scope in the 6R portal. At the midcarpal level, we enlarge the MCR portal to avoid trapping the extensors. And we retrieve the 2 sutures from the enlarged MCR from 2 different points through the DIC. As you can see here, the second suture that we retrieve from the MCR. And finally, we perform the first extra capsular note at the level of the MCR. Here is the first radial enlarged suture that you can see here. We do the same 2 parallel suture from radial to ulnar. As you can see here, here are the second modified suture. So we create the modified MCU between the MCR and the MCU. And we retrieve the second suture from the MMCU from 2 different points through the DIC as well, as you can see here. The second extra capsular note is performed at the level of the MMCU portal. And here is the second ulnar modified suture. So we tract on the 2 sutures, and we perform here the DIC application effect, and we check the stabilization as good, complete, fair. As you can see here, we have a very strong stabilization of the scapholunate space when we tract on the 2 sutures, as you can see here. We perform the final note at the level of the 3-4 portal between the 2 strands of each modified suture. So as usually, the patient is immobilized in a custom splint in extension for 6 weeks. And after the rehabilitation protocol is started, focused in the beginning on the proprioception. We need to avoid the stretching exercises in the first week, as usually. So for the moment, we have only preliminary results. 12 patients were included, 9 EWAS 3C, 3 EWAS 4. The scapholunate space stabilization was considered as complete in the majority of the case. And at 1 year follow-up, all the clinical scores were very satisfactory, except for the flexion, which was decreased by about 17%. And what is very interesting is that the Watson test was positive in 11 cases preoperatively, and it was negative in 10 cases at the final follow-up. So for the discussion, what we can see, and as we have seen before, in the high-grade scapholunate instability treatment, there is no real consensus, and no real surgical procedure has shown its superiority. And the techniques we have for these stages are either open invasive techniques or arthroscopic procedures that are technically demanding. We have seen before the Corella technique, the PCO technique, and we have also some concerns about the hardware and the bone tunnels. And globally, the outcomes are poor and non-reproducible, as it was shown in this recent paper of Greg Bain and Melanie Amarusuya. So we have the enlarged ADCLR in the high-grade instability. It's a very good technique, but we have some limits in the high-grade instability in the chronic cases with some persistent Watson. So when we compare the enlarged technique and the DIC application, what we can see is that in the DIC application, we increase usually the retightening of the DIC. That is the main point. So now, as a discussion, we can wonder which ADCLR technique we should use in which stage. And it is very important to understand that not all the scapholunate instabilities are indication for the enlarged modified technique or the DIC applications, because we know that the more we tighten the dorsal structures and the more we decrease the range of motion in flexion and the mid and long term. So we need, as usually, to indicate the technique intraoperative. This is an intraoperative tailor technique. So here are my personal indication for the EWAS1, as Professor MATHOULIN showed before. It was an acute only the cast. In the mid instability or low grade instability, EWAS2 to EWAS3B, the simple ADCLR is enough, or arthroscopic pinning in the acute cases. And we indicate the more retightening the techniques, the application of the DIC or the large ADCLR in the EWAS3C and EWAS4. And in the more advanced cases, EWAS4 plus, what you can see, what you can say to the patient is, we can start with a non-invasive technique, and it is for me an indication for the DIC application if we perform a very important debridement of the technique, if we refresh the chronic lesions, and we need to say to the patient before the surgery that if this technique doesn't work, it doesn't burn the bridges for a more invasive technique. So this technique, the arthroscopic application of the DIC, showed satisfactory preliminary results. As I showed you, it is a minimal invasive procedure that does not burn the bridges for invasive technique and arthroscopic reconstruction, for example. So it provides a strong scapholunate space intraoperative stabilization. We feel this strong stabilization intraoperatively. And of course, a greater follow-up and larger series are necessary to conclude about the superiority of this technique. And thank you for the attention, and I'm ready for the question. Thank you.
Ahlan, it was impressive. Thank you for sharing us your new concept and techniques in scapholunate ligament injuries. Next part is question and answer. I have here some questions, but maybe because of time limitation. First question is from Abby, Dr. Abhijit. Can you hear me? If you are here. Please on your microphone. So I ask the next question from Professor Yao. The question is there any concern about dorsal TFCC tear instead of peripheral tear in palmar AB, palmar 1B? Professor
Ali,
Yao?
yes, I think you asked for dorsal TFC tears?
Yes. Is there any
Yes.
concern about dorsal TFC tear instead of peripheral tear?
Yes, absolutely. So particularly if the I consider the entire periphery of the TFCC as part of from volar to dorsal as part of the peripheral TFC, and all important in the stability of the distal radial ulnar joint, and therefore it should be repaired wherever it is. So I showed the technique that I use going from dorsal to volar for the majority of tears, that's acceptable. But if for a dorsal TFC tear, then I do favor the outside inside technique that I showed with the two meniscal needles. You need to identify the extensor tendons, particularly the ECU, to make sure those are not involved in your suture when you repair those dorsal tears. But I do think that often I'll go put up to 3 sutures into the peripheral TFC to completely repair those tears.
Thank you. Hi again, Professor MATHOULIN. Do you have any idea? Or... Nice
Yes,
to see you.
The pleasure.
So the other, Dr. Moradi, do you have any questions from the audience there?
Yeah, I'm a question from Dr. Ahlam. I'm interested in now that what's the limit for the chronic lesion for you? It's a
for the chronic lesions for
chronic lesion.
Yeah.
Actually, it's a question for me or for Professor MATHOULIN? Sorry.
For Halam, of course.
Oh no, I think that you are working
together.
Want.
Yes.
I asked for you, but Christophe, if you like.
They are home.
Yeah. You know, in usually in our in the clinics, we don't have the ideal case of a patient who fell just before and came to our clinic. Many cases are chronic cases, and for the ADCLR techniques, what we do usually is that with the bright, as I showed you, all these dorsal structures, the area, especially the area of the DCSS and the DIC, is very important to refresh. And sometimes we can decrease the stage of the instability. For example, if you have a stage 4 with the bright from a non-reducible instability, we can manage to have a reducible instability. So the chronicity is important to take in account, but we can manage it with the refreshment and the debridement. We don't use now so frequently the key wires, just the sutures, and we indicate a simple suture, enlarged technique, or the plication intraoperatively.
Okay, thank you.
So if I can add something, you have to understand that there is a big change in understanding and treating this kind of pathology, not only the scapholunate, but also the other risk pathology. But for the scapholunate, the most important to understand is now we push the nature to find a solution by itself. It's very, and we restore the anatomy. We try to restore the anatomy. It's very essential. Hello, you did the first.
Yeah, he also has a question to Christophe and Alam. Beautiful lectures. Do you have any preoperative indicators that may help you decide whether or not a particular case may not be treated arthroscopically?
So the preoperatively, you know, the most important for me is to make the right diagnosis. And for the right diagnosis, you need different things. We forgot sometimes. The interrogatory is essential. The clinical examination with your thumb is essential. A long time ago, Tim Herberts explained me that you need a finger, and you ask to the patient to show you the wrist where is the lesion. If it's in the middle, of the wrist, it is scapholunate. If it is on ulnar side, it is TFCC. It's not completely true, but it's important. The second thing is a comparative dynamic X-ray. With a normal comparative dynamic X-ray, you have 95% of diagnosis. If you don't have static cases, you can push the arthroscopic gripper. And when you are inside, you decide if you can use only a simple suture or to move until the DIC plication.
I can just add, Jeff, everyone. Sometimes you have some concerns about the presence of a SLAC 1, for example, or a SLAC 2 that we couldn't check and we couldn't diagnose preoperatively. So I think we need to be able to indicate another procedure if necessary. It is rare to make a mistake preoperatively, but for example, if you need to add some radial styloidectomy or some interposition intraoperatively, I think we should be capable to do this and to have the skill. And to say the patient that we can change or add intraoperatively something.
Thank you.